Welcome, bienvenue à notre série sur la loi canadienne de la santé. Ce webinaire se déroulera en anglais, mais nous pourrons prendre les questions en français. So, good evening, everyone. My name is Anne Lagacé Dowson of the Canadian Health Coalition. Welcome to the last of our five-part webinar series on the Canada Health Act at 40. I'm in Montreal, as is our guest tonight, Greg Marchildon of the University of Toronto. Among other things, former executive director and lead drafter of the Romanow Commission report and co-author with another one of our guests in this series, Katherine Fierlbeck, of a book entitled The Boundaries of Medicare, among his many accomplishments. And Greg will also be speaking at our research symposium on Thursday at the University of Ottawa Law School. So we're very, very happy to be collaborating with him this evening. Welcome to you, Greg.
Oh, glad to be here, and thank you for the invitation.
And I just want to clarify that we were obliged to postpone tonight's session with Greg because of a logistics tangle we got into last week. The pharmacare bill has been expedited through the House of Commons and is now before the Senate Health Committee. And we had to rush to Ottawa and just couldn't pull together the webinar as planned. So it wasn't Greg, it was the infrastructure at the CHC that failed. So we're very grateful that he was able to reschedule, and we're grateful that you could join us on this date instead of the planned one of last week. So welcome to all those who are joining us for part 5 of our series. I would invite you to ask any questions that you might have in the Q&A, which appears below our images on the webinar, on the Zoom screen. And we're going to post this session with Greg along with the other 4 talks that we've done on the in the webinar series on the anniversary of the Act on YouTube. So let's just start with this, Greg. I was very struck by what you said to André Picard in the Globe when you were talking to him about the Canada Health Act. You called it almost a call to arms. What do you mean by that?
Well, I'm trying to remember exactly in what context I stated that, but of course, some of the criteria of the Canada Health Act are stated like principles, and these principles are such that when you're looking at universality, or as was discussed last week, accessibility, there are clearly problems that are occurring throughout the country, and that this should be a call to arms to Canadians to get their respective governments, that is provincial and territorial governments, to live up to the terms of the Canada Health Act. And when there's a clear infraction by a province of a particular provision, to also make sure that they make their views known to the federal government, which is responsible, as you know, for the enforcement of the Canada Health Act through deductions and transfers to the provinces and territories. And I agree with what Colleen said last week, which is I too am surprised with the complacency of Canadians and would like all of us to become much more vigorous in defending this ideal that we have of the health system in Canada, Medicare in particular, that is universal health coverage, and our expectations, which are written into the 5 criteria of the Canada Health Act.
The Canada Health Act was created and shepherded through the process of becoming law by Monique Bégin, who was a great proponent of universality and universal access to healthcare as the daughter of a family that suffered and was displaced by the war. And the Act reads, this provision is designed to ensure that every Canadian has affordable access to healthcare. I'm wondering, what does that mean? What does that mean in theory? Like, what was the idea of it when it was penned 40 years ago, this past April?
The idea was that everyone would have access based upon medical need rather than ability to pay, and that there would be no financial barrier at the point of service. That's what it meant in 1984. That was the main problem at that time. And as been pointed out in previous sessions, we have had different types and new types of accessibility problems since then that were not contemplated in the Canada Health Act.
And what would you define them? What are the current, so what were the problems then? I mean, Monique Bégin wrestled that thing to the ground, and it got through, it was voted, it was supported unanimously in the House of Commons at that time. We're talking about user fees, I believe, among other things at that time. So what was the scenario then, and what would you say are the main obstacles now?
Well, at that time, you didn't have to worry about timeliness of delivery of services or access to primary care practitioners, largely family physicians at the time. You didn't have to worry about the amount of time you'd have to wait for elective surgery. You didn't have to worry about going into an emergency department and waiting for 12 hours, despite the fact that you're extremely ill and need service right away. So things have changed, and this means that the kind of issue that was dealt with at the time, it was resolved, but we've, in a sense, live in a new environment. It really began in the early to mid 1990s. And despite the fact that we've had a fair amount of reinvestment in the system, we've never gotten quite back to the situation that we were in the late 1980s and early 1990s. And in some cases, things have gotten worse. And so we have a serious set of access problems. I would say we have portability problems as well. As you know, Quebec is not a signatory to the reciprocal billing agreement with other provinces for medical services. It is for hospital services, but not for medical services, as we've heard in the past in these seminars. And other provinces, therefore, have retaliated by, of course, not respecting Quebec residents when they travel to their provinces and they require payment up front for medical services. And so this is a serious issue that should have been dealt with through enforcement in the Canada Health Act. And there are other areas as well where we're not living up to the principles enunciated in the Canada Health Act, which in one sense is an agreement for funding between the federal government and the provinces and the national conditions that must be adhered to, but in another sense represents Canadians' aspirations and expectations in terms of what they want to see for Medicare in Canada.
Did you know Monique Bégin?
Yes.
So I had the pleasure of working with her in connection with the founding of the Women's Studies program at the University of Ottawa and Carleton, the joint program. And she was the most dynamic, wonderful bilingual person. I wonder what she would say if she was around now, if she could see what's happened. What do you think she'd say?
Well, I'm not going to guess because I had a conversation with her about 6 years ago, in which I can tell you what she said, which is she expressed great concern about the situation as it was developing. And she was very upset that things were beginning to deteriorate and that there didn't seem to be the political will and desire at either provincial or federal orders of government to really take these problems and deal with them. And so in that sense, I think if you're talking about today, if she was still alive, of course, she would be very concerned about the current situation.
She was a pretty, as I recall, pretty straight talker too. I can imagine that her language would have been a little bit colorful.
Yes.
About
Yes, and she could speak to issues of leadership. She I think, is an example of great leadership at a particular point in time. And she didn't have a lot of support in that federal cabinet for the position she took. I mean, ultimately, the prime minister supported her, but she didn't have support right around the table for her position and for the desire to basically create legislation that would deal with the extra billing and user charge problem at the time.
So somebody is asking us, this is Camilla Wilinski, who is asking, how would you recommend Canadians act to call on our governments to live up to the CHA? You were saying we are not combative enough, or we're not rallying around and defending our access. What would you say we should be doing in answer to this question?
Well, I think it's a two-front war. I think that Canadians need to hold their provincial governments, territorial governments to account for the administrative and the delivery problems on the ground. Those are the governments responsible for that. So, you know, at the basic level, that's the first stop. And then the second is the federal government in terms of the Canada Health Act. And I think that you shouldn't, it shouldn't be one or the other. I think you have to do both. And I know that I'm here really to talk about public administration tonight, and I'll return to that issue when you would like, but I think it's really important that Canadians think about what is the best strategy for holding governments to account. And at the federal level, I think it's one in which you basically are prepared to engage the federal government, push the federal government, lobby the federal government to strengthen and modernize the Canada Health Act, to force the legislation into Parliament, to force all parties to basically state their position. Now, the Liberals are supported by the NDP. It's not a coalition government, but on individual pieces of legislation. This should be one in which the NDP would support wholeheartedly. And therefore, there shouldn't be the fear that the legislation would be cannibalized when it would get to Parliament, because the majority should be in control in that situation. It would force the other parties, including the Conservative Party of Canada, to state its position. When Mulroney was forced into that position in 1983 by Monique Bégin, 1984, the Conservatives again had to make a decision. And at that point, the Progressive Conservatives chose to support the Canada Health Act. And that meant that they couldn't change it once elected into government. This time, there's two choices. And if the opposition doesn't like the legislation, it's then forced to say what it doesn't like about it. It's then forced to say by the media and by others what it will do should it be elected into government. And I think it's really important to have that transparency, because sometimes it may be in parties' interest to keep the situation vague and not tell people what their plans are before an election. And I think on this one, we should be forcing all parties to tell us what their position is.
I think you raised an interesting point. I was surprised when I saw that the Conservatives voted for the anti-scab law, which was one of the demands of the cooperation and supply agreement between the NDP and the Liberals. And that must have been a bit uncomfortable for some members of the Conservative Party to vote for that. Yeah. So I think you've got a very good point. Once it's in place, it then becomes very difficult to reverse your position. Bill Toll joins us, and he says what we need is a minister for health, not just a minister of health.
Exactly. And Monique Bégin was a minister for health, and I think she's a great example. And we've had some examples of provincial ministers in the past that have done very similar innovative things provincially. We need leadership at both orders of government for this to work. I can't just have it at one level of government, because the federal government is basically responsible at a very high strategic level, but when it comes to the nuts and bolts, it's your provincial and territorial governments that are responsible for actually administering and delivering the system.
And somebody named June Baxter Blau says to say hi to you. Great to hear you speaking again. So a friend
Oh,
on the Q&A for you. And Ivan Stevens is asking, is there any advantage to using private insurance companies for the administration of Medicare? For example, the new dental insurance program, which is a question that I had on my list of questions. Is that public administration if you've handed it to a giant insurance company?
okay, now that brings us directly to the principle of public administration under Section 8. And if I can be allowed just to give a little bit of background to answer this question. What this principle really means is that the healthcare insurance plan in any given province for Medicare needs to be operated on a non-profit basis by a public authority appointed or designated by the government of the province. And in practice, this public authority is invariably the Department or Ministry of Health. Okay, but there's another part to this, and this is Section 8 sub 2 under the Canada Health Act that allows a public authority to basically delegate or transfer responsibility to an agency for collecting revenues. But this agency must act on behalf of the delegator, and the delegator remains accountable to the government and to the legislative assembly or provincial parliament for this. Currently, there are only 2 provinces where this delegation works. And if you want to read about this, all you need to do is to go to the Canada Health Act annual report, and you go under the provincial reports for every province, and there is a section on delegation in the case of 2 provinces under the principle of public administration. One of them is the province of Nova Scotia, and the other is the province of British Columbia. Now, in the case of Nova Scotia, it is actually a company that's called Medavie Blue Cross.
Right.
Medavie Blue Cross is a non-for-profit corporation. It was created as such to actually do this work of delegating. It's separated from its for-profit arm of Blue Cross. And it is absolutely beholden to the Minister of Health in terms of reporting, etc. So, of course, it receives a payment for this service, but all of its accounts, all of its transactions, all of its activities are reported back to the Minister of Health, and the Minister of Health and the Department of Health in turn report it to the legislature. So you can delegate, but you delegate under these narrow circumstances. In the case of British Columbia, it's the Medical Services Corporation, and that is a Crown corporation. So that is a public body too. It's just slightly arm's length from the government, and it too reports directly to the Minister of Health, but it does it through a Crown corporation. Now, that was a much more common device. We call it a commission kind of an agency. And at one time, about half the provinces operated in that way. But over time, they just found it to be burdensome and not very necessary. So they basically disbanded those Crown corporations or those commissions, and they had the department or the Ministry of Health deal with it directly. And so BC is the last of these, the jurisdictions to do that. And Nova Scotia is unique in its arrangement, absolutely unique. No other jurisdiction has ever done what Nova Scotia did.
And,
So it can be done, but it needs to be done under very carefully regulated circumstances.
and the question was, is there any advantage to proceeding?
Yes.
So you would say
Well,
yes.
that is a more difficult question.
Okay.
In the sense that there were many governments at one time that thought there were great advantages to delegating, which is the reason they did it. Although they weren't really, in most cases, it had nothing to do with financial advantages. It had to do with creating a commission style structure in which doctors would be represented. And doctors would have a direct stake. And that represented the doctor's power in the system in the 1960s after the passage of the Medical Care Act of 1966. But they quickly realized that at times the doctors were frustrated because they did not have a majority vote in the commissions, and what they had hoped for was to have control. Governments, on the other hand, said, well, you can't have control. No interest group can have control. You can have a say, but we're also going to have public representatives and we're going to have government representatives on these. So it was a frustrating situation for both sides. And governments eventually got rid of most of these commission-style structures. As for the Nova Scotia cases, they're a financial advantage. I've never actually seen the numbers on this to be able to tell you one way or the other, but you have to assume that it must cost government something to delegate to a not-for-profit to be able to run that. And I don't know what the difference would be, a commission of 4 or 5%. But there must be a payment of some type. And the question is, could you do it more effectively or efficiently within the department? Most governments have voted with their feet on that question. They feel that they can do it more efficiently within their own departments. Or they probably would have delegated to a Nova Scotia type Blue Cross agency or something similar. But they have chosen not to do so, and I can only assume that they've been rational in how they've approached this. But no one, to the best of my knowledge, has done a financial study of this kind of delegation.
Bonnie Johnson has written in to say she's currently involved in a local rural chapter of the Ontario Health Coalition, and they're trying hard but cannot even get a meeting with their MPP. They've been trying to engage the public as well. And she's a retired health professional. She's really worried about the decline of public health care. And she's asking, where are the Roy Romanows and the Tommy Douglases? Are you seeing any champions rising up in the ranks in either the provincial or federal government?
I'm not seeing very much at this point, unfortunately. And I'm very sad to say that, because I think 20 years ago, I could have spotted out at least a few bright lights and some hope for the future, but I haven't seen much lately. Now, that doesn't mean that that this is going to remain the case. Surely there is going to be someone that will emerge at the provincial or federal level that's going to say, here's what we need to do. And here's, some ideas, and I'm going to engage in a dialogue about these plans, and we're going to do them if the general public agrees. And I think it needs to be courage. Sometimes it comes from strange places. And right now, the one government that seems to be prepared to take on organized medicine and its very powerful lobby is, strangely enough, the government of Alberta. And they are prepared to engage in some experimentation. Now, you can argue that this is going to be, some of these ideas are terrible, but in an area like nurse practitioners, and the exact proposal that's come out in the last month or so seems to me to be better than anything that I've seen the rest of the country from a government that I just would not have expected. So it is a bit of a strange situation that we're in. Now, I certainly hope that we begin to see that kind of leadership from the governments we should expect it from.
The governments of Manitoba and British Columbia come to mind, among others, I guess. But I just saw a survey that was done of the attitudes of people in various provinces to federal intervention. And Alberta and Saskatchewan are now polling at higher levels of opposition to federal intervention in provincial affairs than Quebec is.
Yeah.
So
yes, I think that, and that's probably more to do with certain other issues. You know, when you look at the East-West divide in terms of the energy file and attitudes towards petroleum and the future of petroleum, I think it has much less to do with healthcare. And some of the strongest support in the country years ago, when there were attempts to make changes in Alberta in the 1990s, you know, when Ralph Klein said he was going to basically remove Alberta from the Canada Health Act, there was more support for the Canada Health Act in Alberta among Alberta residents than could be found anywhere else in the country. And that was because the fear was the greatest, but people mobilized. And I think that this cuts across ideological lines, not right across, but there are a whole group of Canadians who may vote differently, but on this one, they're agreed. They want to retain the ideals of the Canada Health Act, even if they're dissatisfied with the current situation. They don't think the answer is moving away from the Canada Health Act or privatizing the entire system.
Trish McAuliffe, pardon me, who's the president of the National Pensioners Federation, says that she feels that seniors are impacted most when the principles are not upheld on all accounts. They write letters to both levels of government. Each government blames the other, and we feel that we're mostly up against the deep pockets of corporate lobbies. I wonder what your comments would be.
Well, my comment would be that actually retired people through their organizations are one of the potentially most powerful lobbies in the country. And if the lobby is focused, if the lobby is prepared to embarrass governments at time, not just lobby them, but make it very clear that they will continue to embarrass the government unless changes are made, I think they could be very, very effective. And I don't think there's a government in the country that could ignore them.
I'm having a flashback to that moment when a senior activist told Brian Mulroney, "You promised us you would do that and you didn't. It's bye-bye Charlie Brown." I don't know if you remember that incident.
Very much.
Yeah, it made the news across the country and Mulroney backed off. I forget what measure he was going to implement. But he backed right down. So I think you have a point there. So Trish McAuliffe, don't give up is, I guess, the message there.
Yes, I think, but it's important to be hard-hitting in this. You know, I think we're just far too polite as Canadians. And if we're going to be members of action groups or lobby groups, you know, as citizens, we should ensure that they enter the arena with pretty sharp elbows.
Ivan Stevens says, "Thank you for that explanation on insurance companies doing administration. I worry we'll pay more, but also that the insurance companies will deny reasonable claims."
Well, that's the thing. And that's, you know, you would never allow a for-profit company, and it's written right into the Canada Health Act, and before that, the Medical Care Act, If you delegate, it has to be to a nonprofit. So it doesn't have those incentives. Second of all, the insurance contract, and this is written into the section on public administration, the insurance contract has to be determined by the government, the terms of coverage, everything. That cannot be determined by the agency you delegate the collection to. And that's all they're being delegated to do. They're being delegated to administer and collect. They're not being delegated to make decisions on the coverage package or access or anything else.
Another thing you told André Picard in that he did a big feature on the Canada Health Act, the anniversary. I think he and the Canadian Health Coalition are the only people who even decided to honor or celebrate the Canada Health Act on its 40th anniversary. And you told him, or you're quoted as saying, Medicare is vulnerable because of problems with timely delivery of services. It's poor governance, not a poor law.
That's right. I think that this is mainly a problem outside the Canada Health Act. I think we can use the Canada Health Act, particularly a modernized, improved Canada Health Act, as a more effective shield. But at heart, the problem is largely at the provincial and territorial level, and making sure that the governance, administration, and delivery better meets our expectations. And we need to be much clearer as Canadians about our expectations as the residents of any individual province. And not all provinces are in the same situation. And where it's worse, whether you're talking about Quebec or you're talking about New Brunswick, that the residents of those provinces make it very clear what they expect of their provincial governments.
Keith Lowe wants to know, is it fair to say that there's an unrecognized or untapped political capital in Canadians' attachment to the Canada Health Act principles? And if so, what would be the best way to maximize
You're right.
that?
And I think the political capital is not often what we think it is. We often assume that the political capital is the fact that we have our self-interest and the interest of our families. But the real value of the Canada Health Act, and this was done in public opinion polling years ago, and a political scientist wrote a very learned journal article about this, is that what Canadians were expressing was their desire that Medicare protect neighbors and people they didn't even know. That was the security they received from it. It wasn't just about them and their families. In fact, it wasn't even primarily about themselves and their families. It was about everybody else. They feel insecure if other people are insecure. And so the political capital here, I think, is one of speaking to that, Canadians, the basic sense of fairness, the basic sort of desire to see everyone taken care of, and to say we've got to get back to that. We've got to ensure that we have a system that does not become a two-tier system in which, you can fly business class if you've got the money, and you are stuck with a substandard economy class if you're part of Medicare. I think Canadians, the majority of Canadians, still reject that basic notion.
No, that's my impression too, that the idea of the ethos of fairness is still very powerful, but it is being dented and undermined by the reality that people are banging up against, which you described in the emergency rooms, 12 and 14-hour waits, 6.5 million Canadians without a primary care doctor, without GPs. I mean, this is very hard on people's morale, and their support of the system starts to fall apart a bit, when they're faced with that.
It is, and latest, most extensive public opinion polling that we've seen from Ipsos Reid is that Canadians fall into three categories. And it's almost 1/3, 1/3, 1/3. There's 1/3, almost 1/3, less, it's less than just slightly less than 30% of Canadians now who feel that Medicare is part of the problem, and they are really looking for an alternative, and they feel that Medicare is at fault, including the Canada Health Act, I think. But there's another third in the middle that still believe in the principles, but they themselves have begun to seek out private options because they just can't get access to a doctor. They've seen what's happened in an emergency department, and they don't like it, but they're looking for options out of that situation to help themselves and their families. And then there's another third that believe in it on principle and are not going to engage in that because they want the current system to work, and they're trying to fix it from within. They're not just opting to see what they can do by spending their own money. If they can, and that middle group, obviously, it's only the people that can afford to opt out that will opt out. And they do so reluctantly. So we still have a majority that adhere to the principles, but some are beginning to look for private pay options in order to help themselves or their families for obvious reasons.
Yeah, we're seeing a lot of that in Quebec, and we're seeing large numbers of doctors not just opting out and billing, but completely opting out and billing directly. As you know, you live in Aylmer, I'm in Montreal. 600 or more doctors have opted out in Quebec versus 12 in the entire rest of Canada in the Rock, which is very, very upsetting to see.
And that is, I'll be quite blunt about it. It's a failure of governance and good political leadership, because where that leads. It then leads to the creation of a private system that becomes a separate tier. You can't have that many doctors opt out without that happening. And the idea of Medicare was that all the doctors would be in, all of the facilities would be in, everybody would have access to any doctor, any facility. It would all be part of a single public system.
And in the case of all of these doctors opting out in Quebec, then there's no public administration at all, really.
That's right. And some provinces historically allow for opting out, including the province that I'm originally from, Saskatchewan, because of the deal that was made to end a 23-day doctor strike back in 1962. But in the past, it was rarely done because you would starve as a doctor if you opted out, because you wouldn't get any patients for the most part. And so most doctors didn't opt out, and the payments were certainly good enough that you didn't have to opt out for financial reasons. And if we look at physician remuneration, that's still the situation. Physician remuneration is fairly high relative to other OECD or rich countries. So that's not the problem. The problem is what's going on in other areas, including some of the obligations that are maybe placed on doctors, but also the opportunity now that's being permitted by provincial governments to make money in the private sector. And when I talk about private versus public, I'm not talking about private versus public delivery. Doctors, by definition, are private contractors. So they're private deliverers, but they're operating within the rules of a public system, or should be. So what I'm really talking about is public payment under public governance and public law and public regulation to ensure that at a minimum, access is based upon medical need, not on ability to pay.
Jeremy Jones is wondering, we often hear, well, we just can't afford it. We just don't have enough money. So Jeremy Jones is asking, will there ever be enough public money or government will to tax the population to achieve the type of medical care that the population desires in 2024? I mean, with increasing healthcare costs that couldn't have been anticipated 40 years ago.
Well, first of all, we are spending a lot of money publicly, and we spend a lot of money privately on healthcare in Canada relative to other countries. Part of the problem here is not the amount of money, it's how it's spent, how effectively it's spent. The second problem is that if you allow opportunities, for example, for physicians or facilities to go onto that private side of the ledger, you're basically allowing resources to move, and you're encouraging people to pay even more privately. They still have to pay their taxes publicly. So overall, this is a system that will encourage even higher amounts devoted to healthcare. But there's only a small subpopulation that benefits from that. The majority are getting an increasingly substandard system.
Gerald Bone is asking, how do you require that the delegated not-for-profits become more transparent? Require them to report publicly? Gerald Bone says, I see a move to more transparency in the US with a little smiley kind of emoji thing, with the Medicare Advantage debate where private insurance companies are delegated to provide coverage.
Yeah, well, in the case of Canada, I gave you the two exceptions to this, and they're under a lot of different rules that require public records to be provided. They all have to provide that. So Medavie Blue Cross has to provide virtually all their financial information to the Ministry of Health. And the Ministry of Health has to then report it to both the government through cabinet and to the legislature. So in that sense, there's lots of transparency. And I don't think anyone would argue that the Medical Services Corporation in British Columbia, as a Crown corporation, is operating in a way that is not transparent. But there are areas, because our system is built on there are private sort of deliverers, and there are times when it's questionable whether there's enough information that flows. Because after all, they're receiving so much public money, they should, in return for that public money, be subject to certain requirements in terms of the provision of information. We do allow all of our provincial auditors in every province to basically audit anything that is arm's length from government but public. So, whether you're talking about regional health authorities or provincial health agencies, Medical Services Corporation, said all of this is subject to auditors, provincial auditors. So in that sense, I think there's a fair amount of transparency, and there's watchdogs, and there's protections built into the system. Where it gets a little iffy is in the case of, and be quite frank with Gerald on this one, doctors who receive the predominant amount of remuneration from a public source, but there's limited reporting. And there's questions about whether there should be more, given the fact that that's almost all public funding going into that sector. Hospitals outside of Ontario are now almost exclusively run by provincial and regional health authorities. and they're part of public bodies. So in that sense, we should have access to those operations and all the information associated with the running hospitals. And then the religious hospitals and other hospitals that remain independent have very strict agreements with these provincial and regional health authorities. And likewise, I think there are major informational demands on those organizations to provide information. Whether it's enough or not, I don't know. I suspect it is, but I'm not positive. I'm not an accountant, nor am I an auditor, but.
So Megan Eade has a question about provincial governments. So what, if anything, can we do against provincial governments that use public funds to pay private practice? In Ontario, private clinics are now running inside public hospitals and are being paid more for the same services, along with receiving infrastructure funding on top of fee-for-service that are also higher than paid to the actual hospital. What can the public do against their own government in such a case?
Well, first of all, there is public information on that. Second of all, I think that you're talking about doctors who set up within hospitals but are operating under the rules of Medicare. Okay, so the most specialists are private contractors of that type, whether they have their offices in hospitals or outside of hospitals or in both places. They are private contractors, but they are required to provide at least some information concerning their operations. And if a citizen is not satisfied with that or thinks that there's something else going on, including allowing a private contractor to provide services outside the rules of Medicare, but within a public institution or a nonprofit institution, I would advise that person to write the Minister of Health, setting out their concerns about this, pointing out the provisions in the Canada Health Act on universality and accessibility and public administration, and demanding to know whether these clinics abide by the rules of Medicare or not.
And then wait to see what response you get.
Well, the thing about it is I can tell you in my experience in government, at least in the 1990s when I was a deputy minister, when a letter goes to the minister, that minister answers and generally involves the whole department in trying to formulate an answer. And they do not ignore that. If they try to ignore it, or they try to basically provide a very superficial answer, they know they're going to get yet another letter demanding even more specific information. So they know that that is a self-defeating proposition. So they try to get it right in terms of a response. If you're unhappy with the response, though, don't stop there. And you feel that you've been, in a sense, either being lied to or the government is avoiding a straight answer, take it to the media and let the media investigate.
I would say, as a former member of the media, there's not much left of the media, but I was just at a meeting of the Canadian Association of Journalists, and there was a very interesting workshop on access to information and how to use access to information as a tool to get that kind of information. At the risk of using the word information too often, that you can request copies of email exchanges. You can even ask for texts. There's all kinds of stuff that you can get. You have to be a bit patient. But somebody like Robin Doolittle, there are some journalists who still use access to information very effectively. And that's
Right.
something that citizens can do too. You don't have to be a journalist to do that.
You don't have to be, but it's hard for the average citizen to do that. So there are two things. One, set it up so that you make the journalist's job easier by having the initial letter to the minister or a follow-up letter to the minister, and then giving that to the journalist so that the journalist knows what to work on. And the journalists can then go through that process. Or if you belong to a civil society organization that is lobbying in favor of that, they may be willing to invest in that process. They may even have somebody that they can contract with or have on staff that could lead that process on behalf of the membership of the civil society organization.
Right. Megan E just wrote back. Well, so Gerald Bone agreed with an exclamation point in response to your comment. So
I'm relieved because I feel like I only answered half of her question. So great. I appreciate that.
And Megan E says there are private knee clinics running as private clinics located inside public hospitals. They are not part of the public system.
Yeah, and that's exactly what you should be writing the minister about, because
Okay.
if they're operating out, they're providing medically necessary services. And we have to remember that both urgent and elective services are part of medically necessary services. So those are Canada Health Act services. And a minister needs to be able to explain how could that situation ever develop.
Megan says the Ontario Ministry of Health simply declines to answer communication. So if the minister doesn't answer, then do you go to the prime minister? Do you send
you go to the, in the case of the province, of course, you go to the premier.
Right. Sorry, the premier.
But if a minister doesn't answer, and you don't think the premier is going to answer either, you go directly to the media with that.
So you go to your health coalition and try and organize some kind of media strategy, because it's not necessarily that easy to do.
Yeah, no. And the idea is, I worked in government. I mean, I'm not trying to advise that the best route is always to embarrass governments, but if you can't get a legitimate answer, and you deserve one as a citizen, as a taxpayer, you deserve an answer. If you can't get that, and they don't even have the courtesy to respond, do not hesitate to embarrass that government. That government deserves to be embarrassed, should be.
Karen Palmer is saying, is expressing some curiosity about when I talked about opted out doctors in Quebec. So Quebec is unusual in the sense that it has three kinds of doctor participation, unlike the rest of the country. There are doctors, 600 or more of them, who are completely outside anything public. They don't participate in any way in publicly administered healthcare, which sounds incredible to people who don't live in Quebec, and even to a lot of Quebecers. So Karen Palmer was wondering about that. So are you following that, Greg? This development of more and more doctors, they come out of medical school and they go straight into the completely private world of medicine. They don't even transit through the public system.
Yes, it's one of the most, I haven't been able to get beyond the newspaper reports because some of the other things that I'm doing. So I know no more than anybody else reading the media, but let me tell you, it deeply concerns me. I think this is one of the most disturbing things that I've seen in a very long time.
This is a story that was reported by Tutan Ha of the Globe and Mail, who lives in Montreal, or did for a long time. He tracked that and he broke that story in the Globe and Mail, and then the French media picked it up. And it is kind of incredible. I mean, the scale of it, only inside the borders of Quebec. There's nothing to compare anywhere else, as far as I'm aware. And here's another suggestion for Bill Toll. Okay. Copy the federal minister of health. If you're going to launch a letter writing campaign and you're going to write to the premier, copy the federal minister as well. You're going to really try and shake things up.
Yeah, I think it's a little bit subject dependent, and sometimes it's, the strategy might be better to try and wait for a response from a provincial government, particularly if you think you're going to get a legitimate response. But if you fear that you're not going to get it, yes, I absolutely agree with Bill on that. CC the federal minister. but then be very clear on the respective responsibilities of each of the two governments in that letter.
Now, can you just tell us quickly, Greg, because we're coming up to the end of our time together, you and Bill are tag teaming each other at the symposium on the 20th, on Thursday, but you're also working, there's an article that you worked on that will be published soon?
Yeah, Bill and I decided to put some of our thinking into a piece for policy options to basically say, well, where do we go from here? And here, this is from the perspective of Canadians and citizens. We're waiting to hear word as to whether it's been accepted. So hopefully we'll hear back shortly.
Okay. How would you explain this to Karen, Greg? So she says in BC, we call those Quebec doctors non-enrolled, not opted out. BC differentiates between enrolled, non-enrolled, and opted in, opted out.
Yeah, I think that my short answer is I would have to study it intensely to know whether it's parallel or whether there's something else going on in Quebec. My feeling is that something else is going on in Quebec.
Yeah, that's certainly how Tutan Ha presented it in the Globe. These are people who are disengaged completely. They operate standalone, entirely commercial clinics where you pay with your credit card only, and there's no reimbursement of the amount that you've paid.
That's right. And I think only in Quebec is that kind of practice permitted to that extent. And this started a long time ago with diagnostic clinics, et cetera, in Montreal, in the Montreal area, where you had all of these private MRI and CT scan companies set up by physicians. That didn't happen anywhere else in the country. There was no parallel. Now, since then, of course, there have been some, I would call them non-Medicare private diagnostic clinics set up. But they, in other places, they're an exception. In Montreal, they're part of the landscape.
Yeah. And in fact, the new head of the health agency, which was just set up by the CAC government, comes from a company that provides those kinds of private diagnostic tests. That's called Biron. Her name is Geneviève Biron. She inherited the mantle of the company founded by her father, and she has no experience in the public sector. And she's now going to be responsible for almost the entirety of the health budget, as I understand it.
Mm-hmm.
That's how far gone it is in Quebec.
But I don't want to put all of the emphasis on Quebec. We're facing problems in other jurisdictions as well. This isn't, it may be more down the road and extreme in Quebec, but there are other provinces where we face major, what I would call both violations in spirit and the law of the Canada Health Act.
In closing, Greg, what would you say to our almost 50 participants right now? You started out by saying Canadians are a bit too polite and surprisingly uncombative in some ways, but clearly the 1/3 that really cares a lot and the 1/3 that is still concerned but kind of a bit defeatist is still there to mobilize. So I wondered if you could close with some words of encouragement. And then those people who want to hear more from Greg and Bill Toll, they should try and join us at the symposium in Ottawa on Thursday if you can make it. Otherwise, you can watch it also up online later.
Well, let me just say that historically, Medicare would never have existed if the people of Canada had not wanted it. It's certainly most of the organized, powerful interests did not. In fact, a majority of provincial governments did not. And there were powerful elements within the federal governments of the day that didn't want it. It was only the pressure of the Canadian public that made it exist. And yes, there was leadership, political leadership, but it was the Canadian public ultimately. Looking to the future, only the Canadian public will be able to ensure that Medicare can continue, and they need to make it known that they will make their representatives suffer at the polling booth and in other ways if they don't take this seriously. So this is a, you know, a call to arms to Canadians. Only we as citizens can really protect and strengthen this program.
And on that inspirational note, I think we'll close tonight's proceedings, but I really thank you very much, Greg Marchildon. It's really a pleasure to meet you on Zoom, and hopefully we'll get a chance to chat on Thursday at the Research Symposium. Thank you very much for all of your diligent and thoughtful insight. And thanks very much to our participants. Wonderful, great questions. I'm sorry we didn't get to everything, but we will put this up on YouTube, and we'll pursue some of these subjects as the struggle continues here at the Canadian Health Coalition. We certainly don't intend to give up, and we are very reliant on you and your support and your insight as well, because the Canadian Health Coalition is indeed a coalition of healthcare workers' unions, of experts and scholars like Greg and Joel Lexton and many others, and individuals and civil society groups such as the Citizens for Public Justice and the Canadian Federation of Students and various other civil society groups. So thank you so much for joining us. And don't forget, June 20th, we close off our celebration of the Canada Health Act with an all-day symposium at the University of Ottawa at the Law Faculty, under the auspices of the University of Ottawa and Vanessa Grubin, who's on our board, and St. Thomas University of Fredericton. Thanks very much to Tracy Glynn for stick handling the tech, and to my colleague Steve Staples and outgoing chair Pauline Worsfold and incoming chair Jason McLean. So that's it for us. Merci beaucoup. Merci à tous. Portez-vous bien. Ne lâchez pas. Don't give up.